Okay, I also kind of wanted to walk you through some of these ATI things. So these large paragraphs are really repetitive. It's just very, very, very repetitive. So here we already talked about primary reason for COPD, those noxious gas that makes you feel nauseous, right? It's a combination of chronic bronchitis and emphysema. We've already talked about the pathophysiology. We've already talked about the pulmonary vasculature and the lung parenchyma. These are those, a sinus or whatever, and the lung parenchyma is the capillaries with those a sinus, the word I couldn't pronounce. Um, so this is where the emphysema subtypes come in. So that proximal is usually associated with, right, proximal. We're proximal to smoking or coal. Proximal to smoking and coal. Um, anti, right? Associated with alpha 1, anti, anti. Distal pneumothorax. Um, Abnormal dilation of the respiratory bronchiole. I feel like it's more important we know what they're associated with, what disease states. But this is a chart that's really good. This is basically talking about what we talked about. The most important thing is 3 months and 2 consecutive years, along with mucus overproduction and airway inflammation. That is the details for chronic bronchitis, right? And then they're just kind of talking about like how does smoke make this happen? We have increased goblet cells, more more mucus secreting glands, lowered ciliary function, which is those little arms that brush it out in your lungs. So mucus plugs the airway, yada yada. Let's do a little quiz. Match each subtype of emphysema to its commonly associated causative factor. So I'll give you like a minute. All right. If you said distal goes with distal, you're correct. So remember, anti, right? Anti. Proximal to smoke. Yep, you got it. Etiology. So this is basically how does chronic bronchitis happen? So noxious gases that make you nauseous, right? The manifestations of emphysema begin after at least 20 packs per year of smoking or exposure. So if anything, just try to remember 20 packs. Manifestations of emphysema begin at least 20 packs per year of smoking or exposure. So 20 packs. These are the risk factors that we talked about already. Which of the following statements about risk factors of COPD is true? Smoking is the most important risk factor of COPD. Men are more susceptible to developing than women. Environmental exposure to dust, vapors, and fumes do not increase a person, so we can cross that out. Smoking, both tobacco and marijuana, do not increase, so we can cross that out. Now, what's wrong about here, right? If we look at our risk factors, female is a higher risk factor than men, right? So men are not more susceptible to developing COPD. But we do know, even if we didn't know what the word susceptible means, we do know that smoking is the most important risk factor of COPD. Okay, comorbidities. We talked about this as well. So asthma, right? That's a big one. Quality of life is bad. Asthma coped COPD overlap. Here's some other cardiovascular disease, hypertension, metabolic syndrome, bronchiectasis, right? So if we just think about airway, this is the hypertension, hyperglycemia, and there was another age. And then they're more likely to experience depression and anxiety. Epidemiology, this is where we talked about Men are more prevalent to have it than women. Worldwide, there's a 10.3% prevalence of it. And COPD is the third leading cause of morbidity and mortality. Clients with COPD have an increased risk for pneumonia, right? That's why we want them to get those pneumococcal vaccines and RSV vaccine, as well as flu, because that can lead to pneumonia. So systemic effects of COPD: weight loss, skeletal muscle dysfunction, poor nutrition. Right, and that kind of makes sense. Think about if you're not getting enough oxygen, it's going to be a problem. Psychosocial, depression, anxiety, linked to lower quality of life. COPD also increased disability and higher mortality rates. Advanced age is a huge risk factor. So the older someone is, the more of a risk factor they are. Clinical presentation. This is all about what do they look like when they're having like exacerbation. So we have wheezing, dyspnea, sputum production, chronic cough, chest tightness. Those are like the big things we need to remember. This whole paragraph is a lot. So the onset of sputum production progresses from morning only eventually to occurring throughout the day. I feel like this is really important. So when it's early on, they may just experience sputum progression in the morning, but as COPD continues to progress, they'll have sputum throughout the entire day. It's mostly mucoid except during exacerbations where it's purulent. Ew, stinky, it's purulent. It's gross. It's caused sputum, wheezing, fatigue, dyspnea intermittently. They can present like other conditions, so it can be really hard to differentiate the diagnosis. All right, here they mention again, is it common for manifestations to occur in the morning and variability to occur throughout the day or week? Right, here we go with the morning thing again. So they really want us to know manifestations occur mostly in the morning, and as the disease progresses, it can happen more and more throughout the day. And here we go. They may experience weight gain from lack of activity or weight loss due to dyspnea frequently, right? Because if you can't breathe, you don't want to eat. Weight loss is a manifestation of an advanced condition, right? Poor prognosis, anxiety, and dizziness from coughing. In early stages of disease, prolonged expiration and forced exhalation accompanied by wheezing may be present. So someone has a hard time breathing out and they kind of force it. So like, right? They're trying to get out the trapped air. Physical findings of COPD are usually only found when the disease is severe. So we have that barrel chest, right? Continual expansion of ribs, limited lung elasticity, decreased breath sounds, wheezes, and crackles. So this is all what we're going to hear and what we're going to see. They'll sit leaning forward slightly, which allows them to use accessory muscles of the neck and shoulder girdle to breathe. Pursed lip expiration and Hoover sign, which is drawing of the lower ribs while inhaling, that's our Hoover sign, are also present. Neck vein distension is also going to be present. Yellow stains on fingers or tar. All right, physical findings of COPD are usually found when this disease is severe. Which of the following physical findings would a nurse know is considered a feature of severe COPD? Increased breath sounds? No, they're going to have decreased breath sounds, right? Are they going to have relaxed or distended neck veins? Distended. Prolonged inspiration, or is it going to be prolonged expiration that's forced out, right? Let's go with C, barrel chest. Yay! Laboratory tests and diagnostic studies. So, spirometry, right? So this is the thing. So the capture questionnaire can be used to identify clients for the evaluation of COPD. The capture should be used along with peak expiratory flow measurements. So that's what we were talking about with the FEV1 and the FVC. A score of 0 to 1 is not considered at risk for clinically significant COPD. A score of 5 or 6 indicates symptomatic respiratory disease is likely and would require evaluation, including spirometry. A score in the middle range of 2 to 4 is when low peak expiratory flow determines whether further diagnostic evaluation is needed. So basically what they're saying, if you give a patient this capture questionnaire and they get a score of 0 to 1, they probably don't, there's no significant development of COPD happening. Score of 5 or 6, yeah, we need to look into that. And a middle range of 2 to 4, it's like, well, you know what? Let's do a spirometry and see, or like let's just come back to it. There could be a risk, there could not be a risk, right? It's that middle ground. Capture, I don't know what this is about. I don't like this. You're just trying to capture their breath back, right? Trying to capture their breathing. All right, laboratory tests are sometimes evaluated to exclude other causes of dyspnea, right? Like, let's say they can't breathe, but they have something stuck in their throat. You want to, sorry, I was thinking, wrong thing. Okay, so for example, assessment for anemia is important when evaluating for dyspnea. If a client has elevated serum bicarbonate, so bicarb is the buffer that our kidneys use to keep our acid-base balance in check, right? They produce bicarbonate. It helps keep our acid-base balance in check. So elevated serum bicarbonate may indicate hypercapnia because that means your kidneys are basically compensating for your lungs, which are not breathing well, and they are not getting rid of the CO2. So your kidneys have to get rid of CO2 by making more bicarb. But further testing should be done through alpha-1 antitrypsin deficiency for clients where spirometry tests show consistent obstruction of airflow. Just forget that. Just remember, we do lab tests, and the one that we're really looking at is serum bicarb because it can indicate hypercapnia, which is too much carbon dioxide, CO2, in the blood. Pulmonary function tests. This is the cornerstone, is spirometry. That's really the most important thing. Important values gathered during spirometry tests include forced expiratory volume and forced vital capacity, right? So cornerstone is spirometry that measures these two things. GOLD guidelines outline to use these values, the FEV1 and FVC, to determine the threshold ratio that indicates the limitation of airflow, which is FEV/FVC. So GOLD guidelines, whatever those are, they basically are like, you're going to find these values with the spirometer, and that's where you're going to determine if someone has COPD and what their limit of airflow is. Pulse ox assesses blood oxygen saturation, convenient, non-invasive. Chest x-rays performed when dyspnea or sputum production is unclear, and we need to rule out other conditions like pneumonia or heart failure, right? Okay, so complications of COPD include thromboembolic diseases, thromboembolic diseases, right? So those are blood clotting in veins. So that's a problem, right? If we get a blood clot in our lungs because we can't breathe and blood is messed up. Yep, okay, so complications include we're going to have blood clots in our veins, which is what that means, lung cancer, respiratory failure, and they're all in life-threatening conditions. Respiratory failure requires ventilation. COPD exacerbation of respiratory manifestations worsen. So you have really like a lot of coughing, a lot of mucus, a lot of inflammation. Worsening, it's defined, exacerbation is defined by worsening difficulty in breathing or dyspnea, more mucus happening, sputum volume increasing, and that purulence. So it smells bad, right? It's gross. Mild exacerbation of COPD is described as one manifestation worsening, such as your cough gets worse, you develop a fever, you have wheezing, or an infection within 5 days. That's important. Moderate and severe exacerbations include 2 or 3 manifestations at once and can include acute respiratory failure, hypercapnia, or hypoxemia. So we have basically a mild exacerbation, which is one manifestation getting worse, moderate and severe exacerbations, which is 2 or 3 manifestations getting worse. So I think what I remember for this, like if I was gonna like take a note, I'm just gonna pretend to take a note here. So COPD exacerbation criteria. Mild equals one manifestation getting worse. Mod to severe, 2 or 3 manifestations getting worse, right? And that could be your sputum production's worse, the sputum volume is more, the purulence is worse, the coughing is worse. And 2 or 3 is like 2 or 3 of those things, like the coughing, volume, or purulence is getting worse. All right, question. A client presents with manifestations of COPD. A nurse completes the nursing assessment. Prior to the physician seeing the client, makes a note that the client's airflow is limited. Which of the following tests will need to be ordered to determine the severity of airflow limitation? So we're okay. Client's got COPD. Nurse is assessing. We want to figure out how limited the airflow is, right? We want to figure out the severity. So are we going to do laboratory testing to look at blood levels, right? Serum's usually like blood. No, we're not going to do that. Are we going to take a photo? No, because we're just trying to do like a step 1. So we're not going to get any pictures. Blood work to determine anemia, we're not going to do that. We're going to do pulmonary function tests like the spirometer. Perfusion. Congestive heart failure is a differential diagnosis of COPD where a chest x-ray will reveal a dilated heart and pulmonary edema. Pulmonary function tests often indicate volume restriction instead of airflow limitation. So they're basically just saying pulmonary function is going to tell you it's going to be more descriptive, like how much volume you cannot hold with your breath rather than like how much air you're putting out or in. Abnormalities in gas exchange result in hypercapnia and hypoxemia as the exchange of oxygen and carbon dioxide becomes worse over time, right? You have more carbon dioxide, less oxygen. The increase in dysfunction of alveolar ventilation and reduced pulmonary vascular bed result in an abnormal VQ ratio. Pulmonary vascular blood flow gets worse as the disease progresses and leads to pulmonary hypertension. I'm not really understanding why they put this in here. Congestive heart failure is a differential diagnosis of COPD. I'm not really understanding what that has to do with the rest of the paragraph. What I would take away from this, alveolar ventilation is basically like the exchange of the fresh oxygen with the CO2 to be breathed out. And that's kind of that VQ ratio. It's the ventilation perfusion ratio. So perfusion is like, the ventilation's like what the air, you know what? Let's just look it up. Ventilation perfusion ratio is a measure of the balance between the air that reaches your lungs, ventilation, and the blood flow circulating through them. So those alveoli, as the air is going down through your bronchioles to the terminal bronchiole into the alveoli, those little balloons, that's the ventilation. Now we have the capillaries around those little balloons because the air is being exchanged, right? We have oxygen molecules in the air. So the blood needs to get oxygen to the organs, right? So the capillary beds surround the alveoli so that they can pick up the oxygen from the fresh air, deposit the CO2 into the alveoli. So the alveoli basically, when you breathe out, you're pushing out the CO2 that the alveoli have gotten from your blood, right? So that's basically this ratio is like how much are you breathing in versus how much is the blood basically picking up the oxygen from the alveoli. That's kind of what we're talking about. I would say that's the most important thing out of this. Clients with COPD are increased risk for skeletal muscle loss due to prolonged bed rest, sedation, and mechanical ventilation. That makes sense, right? So what do we need to do? Dietary support, early mobilization. All this stuff is role of the nurse, which you're always so good at. So we need to figure out environmental factors that contribute, right? Which is all of these things: air pollutants, fossil fuels. So, few examples: sulfur dioxide, nitrogen dioxide, and particulate matter. Okay, clients with moderate to severe may also experience anxiety during exacerbations. That makes sense, right? They can't breathe. So, what's important? We need to be calm. We need to be reassuring. We need to be focused on them to help reduce their distress and support them. We also need to educate them on how to minimize exposure to those irritants like the sulfur dioxide, the nitrogen dioxide, and the particulate matter. We need to tell them how to reduce those. So, we need to improve indoor air quality, use protective equipment at work like a mask, avoid secondhand smoke, right? Identify and address risk factor exposure, encourage smoking cessation interventions in clients and their families. So you need to stop smoking. Recommend ventilation that's efficient. If they're like working with fumes. So we need to just reduce their exposure to these toxins. Stop smoking, wear a mask, etc. Clients with COPD require an assessment of their airflow obstruction, manifestation history, and exposure to risk factors to guide their management. So we need to know all these things in order to help them manage their care. So we need to individualize this approach. We need to provide teaching on how to manage breathlessness and stress and conserve energy. We can refer them to a pulmonary rehabilitation person and discuss physical activity. They need to understand the disease and how it progresses. They need to be able to recognize and manage symptoms. And they need to understand that stop smoking is really, really, really important. Nurses also need to provide information about pulmonary rehabilitation, support groups, and clear guidance on when to seek medical attention for worsening symptoms, right? So that makes sense. We want to make sure that they're getting support outside of the hospital, and we want to make sure that they know when they need to get medical attention. Teaching should promote self-management skills, right? Medication use, energy conservation, breathing techniques. So clients need to really basically take a leading role in their own disease management. This is where we get, what does it look like after 1 week, after a month, when they stop smoking? Blood oxygen levels increase after 1 week. That's good. After 1 month, their activity gets easier and they have increased blood circulation, which is good. Also, coughing and congestion decrease. Long term, quality of life improves, complications decrease, respiratory illness decreases. Nursing process, we need to recognize the cues, right? So we need to obtain a history. We need to complete their physical. We need to ask them about what's going on. What are they experiencing? We need to assess a cough. We need to listen to their breath sounds, right? We need to get that stethoscope out. We have to, assess their intolerance to activity, have them walk around a little bit. We need to see how much stuff they're coughing out. We need to make sure that their mental status is okay, and ask them about their history of smoking. So we should inspect the chest wall and use of accessory muscles and assess for edema in the extremities and if there's any blueness that we see. And obviously, we need to do pulmonary function tests, which is our spirometer. Analyzing cues, so that could mean if they're gasping for air, that's a problem and suggests dyspnea and respiratory distress. If the client is showing fatigue, respiratory failure, we need to assess vital signs. We need to look at blood pressure, respiration, or pulse, right? We need to listen for adventitious lung sounds like wheezing or rhonky. and look for bronchospasm. So we need to now analyze. We need to ensure the client they can breathe and that they have enough oxygen. So when we assess the respiratory effort, the lung sounds and pulse ox, after these assessments, then we need to figure out what do they need to maintain a usable airway and maintain adequate oxygenation. So now we plan. So we need to aim for normal O2 saturation of 95 to 100, right? After we collect all this data, then we can determine what is a normal saturation for them, right? Because people with COPD might have to have lower oxygen saturation levels. We also need to provide a relaxed environment so they can rest. And then apply the oxygen, right? Promote rest, promote breathing exercises. Pursed lip breathing moves air out of the lungs. Elevating the head of the bed creates a comfortable position to breathe easier. So takeaways from here, promote rest and breathing exercises like pursed lip breathing, right? Because it helps them get the air out. Elevate the head of their bed in a Fowler's, like a semi-Fowler. Administer medications. So we can give them the SABA if they're having like an exacerbation, they need something, and then steroids reduce inflammation and mucus. So now we need to, for evaluating outcomes, these breathing rates and arterial blood gas values. So when airway patency is improved, pulse ox, ABGs, they'll also improve. So smoking cessation is a good goal. Pulmonary rehab is a good goal for them. We can give them community resources. All right, nurses plan care for client who has COPD. Which of the following interventions should the nurse use to achieve an outcome of improving airway patency through adequate oxygenation? We should administer medications, encourage rest. This is what we would do during like evaluation and right. So we're doing interventions now. We're doing things. We're not assessing anymore. Treatments and therapies. So we want to control manifestations, minimize exacerbations, and avoid mortality and improve quality of life. So vaccinations for people who are over 65. Get that PCV13 and the PPV23, right? 1 year apart. They should also get the respiratory syncytial virus, RSV, and the flu shot. They can get the LABA, SABA, and inhaled corticosteroids, muscarinic receptor antagonists, and methylxanthines. So albuterol, relax smooth muscles. These are used in treatment of COPD. For immediate relief, SABAs are used. LABAs are used for long-term management of the condition. SABA short-term, LABA long-term. Anti-muscarinics block M3 muscarinic receptors. So that's the receptor on the smooth muscle, right? They're going to help reduce bronchoconstriction. Short-acting anti-muscarinic agents such as ipratropium or tiotropium provide quick relief. Long-acting provide maintenance therapy. So here we go. First-line COPD uses LAMA with a LABA. There are single inhaler formulations available, such as formoterol or glycopyrronium, or olodaterol and tiotropium, which can increase adherence to the treatment plan. Methylxanthines are used after these two things have been tried. If this is still not working as a first line, then you put your patient on this. They relax smooth muscle in the airway, create mild bronchodilation. Theophylline is commonly used in combination with salmeterol. Corticosteroids can be used in combination with LABAs and LAMAs. So here's our first line, and if that's not working, we can use corticosteroids. Excuse me. It's going to decrease corticosteroids are going to decrease inflammation. Now, here's the general side effects of bronchodilators: trembling, headaches, dry mouth. Corticosteroids such as Decadron can have weight gain, diabetes, and osteoporosis. All right, which of the following classes of drugs used for COPD blocks the M3 receptors in smooth muscles? MM. right? Antimuscarinics. I was about to do, I'm like, nope. Antimuscarinics for M3 receptors. And that's basically um, where I got my notes from. My notes are missing, uh, they're missing this, the capture. So that was the questionnaire. If they get 0 to 1, they're not at risk. If 5 to 6, yeah, they definitely need to do spirometry. 2 to 4 is, whether we're going to decide to move forward with evaluation or not. So that's the capture thing. We're just determining what is their risk level for COPD. My notes also did not really include this, but the most important thing is really understanding that the dysfunction of alveolar ventilation, so when the oxygen comes in and the alveoli are picking that up, and the reduced pulmonary vascular bed, so that's the capillary bed that's around those alveolar. So if this relationship between the alveoli and the vascular bed is dysfunctional, this results in a poor ventilation perfusion ratio. So basically, the air is coming in, but the perfusion's not really happening. The perfusion, meaning the oxygen in the blood that's going to be delivered to the tissues, it's not really happening. So that's a bad ratio between the reduction of our vasculature and dysfunction of our alveoli. Produces a bad VQ ratio. Mobility seems pretty straightforward. Role of the nurse, we got to educate and tell them to stop smoking and avoid those pollutants, right? Avoid those noxious things like sulfur dioxide, nitrogen dioxide, particulate matter. We got to avoid those things. We need to minimize exposure. We need to do proper masking, right? So safety considerations, and then take all this into consideration with individual factors. We need to teach them how to take care of themselves, how to manage their symptoms, know when to reach out for help. This is a really good chart. I would study it. We need to recognize cues, so we need to assess, get a patient history. We need to listen to lung sounds. We need to watch them use their accessory muscles. We need to analyze all of this and decide, what is the next best step. And then we need to come up with a care plan. We need to take all this and come up with a care plan and generate solutions, including giving them oxygen, right? And promoting relaxation, and breathing exercises. So treatments and therapies, we talked about some of those medications, including the corticosteroids. We're going to use LABA and LAMA as a first line. SABA is going to be our rescue in here, like albuterol. And then theophylline, methylxanthines are going to be after these things don't work, and corticosteroids can also be used after these things don't work. We need to look out for these side effects as well as weight gain, diabetes, and osteoporosis. So I really hope that helps just make ATI feel a little bit easier today.